Hey and welcome to the EYFTM podcast brought to you by the EYFTM podcast team. This podcast is accompanied by a study on listening behavior. Nadine, what's the study about?
Hey Fabian, I'm always listening to podcasts when I'm on my way to university every day. And I'm sure most of you are listening to podcasts too in your everyday life. But have you ever wondered how different podcasts influence your career choices or your personal life?
Well, if you want to find out more about the study, there's a link underneath this podcast in the bio. And now,
have fun with our EYFTM podcast.
Hello and welcome back to our 13th episode of the EYFTM podcast. My name is Fabian and today we are recording from a very unusual location. We are recording from Kampala, Makarere University in Uganda. And I have a very special guest here with me, a very young professional who's had a lot of experience in primary care and family medicine, Dr. Innocent Besigye. I hope I pronounced that correctly.
Yes,
thank you very much.
That's correct.
Thank you very much for taking the time today and inviting us to your offices at the university.
Thank you very much, Fabian, for coming over to visit us, and we are really looking forward to a fruitful conversation.
Innocent, you are quite a star in African primary care, family medicine. You finished your university here in Uganda, where you work now, but you're also the treasurer for Wonka Africa, and you're also very interested in medical education, but you also have quite a strong interest in public health research, but also clinical care. I wonder, how do you get all these different interests into one head?
Yeah, thank you, Fabian. I am Innocent Besigye, and as you have rightly said, I am actually a younger professional in family medicine and primary care in Africa. And some of the things I've mentioned, I actually do much more. Currently, I am a senior lecturer here in the Department of Family Medicine at Makarere University in Kampala, Uganda. And I did my training here in family medicine at Makarere University.
Can you take us through training in Uganda? How does it work? How's it set up if you want to become a family medicine physician?
If you want to become a family medicine specialist, you actually have to first do an undergraduate medicine degree, which is Bachelor of Medicine and Bachelor of Surgery, and here we call it MBCHB. And after that, then you can enroll for a master's degree or residency program in family medicine, which takes a minimum of 3 years. So if you are able to go through the academic requirements in 3 years, of course, sometimes some take 4 for various reasons, or 5, and then it is a specialty recognized by the government. So that is how we do the residency training. And here, it is actually based in the district. So this office where we are is within the university, but our training is actually far away, and I think we shall have a brief discussion about it. So I trained here as a family physician at Makarere University. When I was training, I was recruited as a tutorial or a teaching assistant, and I have raised through the ranks of assistant lecturer to lecturer, and now I am a senior lecturer. And now I think I'm remaining with only 2 other ranks to actually reach the top. And I think it is also important to mention, like you said, I do very many things.
Yeah.
I do research, I provide clinical care, and I also do community service.
And you also teach, and we're sitting in your office, and you have a lot of exams right here around us.
Yes, I have a lot of exams around here, but I do several other things. I want to let you know that we have a newly formed College of Family Physicians, because our family medicine training for decades in many African countries, apart from West Africa and South Africa, were based at the universities. But we think the university training has quite some limitations in terms of numbers. So we have just started the college, the Eastern, Central and Southern Africa College of Family Physicians, which is going to be doing a parallel training of family physicians, basically focusing on clinical care.
Is that for undergraduate?
No, for postgraduates.
It
will actually be another program that will be sort of doing residency training to add on what the university is actually doing. And I'm the president, and it covers 9 countries in sub-Saharan Africa. So we really do so many things. I have also been the member of the Primary Care and Family Medicine Network, which is actually the academic arm of Wonka Africa. The Prima Famed Network is a network of 40 institutions in 25 sub-Saharan African countries. And as departments of family medicine, we work together to promote quality family medicine and primary care training. But we work basically under the Wonka Africa as the academic wing by doing research and building capacity for research and education for family medicine and primary care. As you also said, I'm the treasurer for the Wonka Africa, and so we do several other things. I'm also the president of the Association of the Family Physicians of Uganda. So it is many things. And I think I wanted to mention this. Yeah. When somebody hears this, will wonder what is happening. It is because we are very few family doctors in this part of the world. Yeah. So we have to do so many things. That's why you see I have so many scripts, so many things in my office, because I have to teach undergraduates, postgraduates of different years. So I have to make sure everything moves together.
It's incredibly impressive. I don't know how to get this into your normal day. Let's go back to the education in the postgraduate training. So if you were a medical student, finish university, and then you decide to become a primary care physician, what would it look like? What would a normal day look like for you if you are in postgraduate training in Uganda?
Our residency program is a full-time program. So your normal day is that I don't think you will have a day or a description of a normal day, because day and night you are actually in the hospital.
Oh, like day and night. Yes, so you live there essentially.
You live there, and yes, because
for 3 years.
For 3 years, because you come to the university, you report, and then we deploy you at the family medicine training site, which is about 250 kilometers from here in the eastern part of Uganda. It's actually just a few kilometers from the Uganda-Kenya border. Nice. And the reason why we do that, that most of the Ugandan population is rural. So we want to train our residents or our family doctors within the contexts where they will be working after graduating. We have a house there. It is sort of a hostel where you go and you will stay there, which is near the hospital, and then you will be in hospital almost all the time doing your clinical work. We also have a resident faculty there who oversees the running activities of the residents.
That's very impressive.
So the normal day, you wake up, you will have tutorial with the resident faculty there, and then from there you go to the ward to start providing clinical care, and then in the afternoon, if you is when you also do some procedures. And here in our setting, family medicine, as you know, is highly contextual. Yeah. So our training includes extended procedure skills. Yeah. Our residents do major surgeries because
there's no one else.
There is no one else, yes. So they have to actually do the surgery.
You're not only a primary care physician, but you are actually the first physician who's there in any situation. Is that right?
Actually, in Africa, we have done studies. Really, family physicians are not primary care providers. Because if you understand the primary care system, we have other cadres. For example, clinical officers. We also have doctors who do not have postgraduate training practicing as general doctors. So when you are a family physician or a family doctor, you are not actually a primary care provider. You are a secondary care provider. So we act as consultants to the primary health care team.
Can you explain the idea of a clinical officer for us?
A clinical officer is a mid-level clinician. They are not doctors, but they do a 3-year training program.
Is it like a physician assistant?
Yes, sort of a physician assistant. But they don't do surgery. But they actually see patients with other medical conditions.
Can they prescribe medication?
Yes, they do prescribe medication.
Right.
What they actually don't do is surgery. Of course, the training is not strong enough, but I think the reason why we have those clinical officers is because of the shortage of doctors. So it is a mitigation measure of the sort. So they work in lower level facilities mainly, but they also work in hospitals where the doctors are not enough. So the family physician, if you can actually do the ranking, ranks high up in the medical care team. Right. And that is why we are not primary care providers, though our wish is actually that we have enough family physicians to be in all of the facilities, in all of the communities, so that we play our actual role of providing primary care. But for now, we are actually not providing primary care in its real sense, but we are actually supporting other healthcare providers in the form of capacity development, clinical governance, leadership and management of health systems. I really providing primary care as a family physicians. We do it, but it is not our major area of operation.
So when we go back to your rural facility where you train your postgraduate doctors, I'm just trying to picture what it's like living there. So they have a hostel there, so they have their own room, but they're also on duty 24/7, 7 days a week, or do they get days off?
Yeah, they actually do get days off. Before, when we had quite few of them, they would actually, you have to be there all the time. Because, we provide, in the training, it involves training, doing emergency surgery and obstetrics. And these are conditions you cannot plan. So if you are there in your hostel and there is somebody with obstructed labor, you will be called upon. You have to come and do the surgery. And that is why they live near the hospital. It is not that they are going to be in hospital all the time, but sort of they are on call most of the time. And because now we have slightly a larger number of the postgraduate trainees in family medicine, there is some flexibility. So all they do is make sure that somebody on call, and then the others
they have a
bit time off. And they also try to see that the weekends are a bit light, so not everybody has to be present during the weekends, because we know that as human beings, though they are students, we don't want them to suffer burnout.
Exactly. It's actually a very important word, burnout. What's your perspective on burnout? Is it common in your students?
I think for most of us, really burnout is quite common in our students, but also even in ourselves, because we work long hours. Like I'm saying here, I don't even know how many hours I work per week. So many meetings, teaching activities, research. So we actually all suffer burnout. But we think, of course, when they are students, it may even be much more. There is the inherent stress of being a student. So burnout is a common occurrence here. But I think what you haven't done, we really have not documented its extent. Yes.
Do you have a secret trick to avoid it?
Yes, the secret trick of burnout is basically learning how to effectively manage time. And personally, I run a few courses on stress management for our residents, which I actually do when they come. And I always take them through how to prioritize your activities. And one of the tools we use is the Eisenhower matrix, which I know is well known to people, that you prioritize your activities. And even it's also helpful to me, like I mentioned, I have time for research, I have time for teaching, I have time for community service. And by the way, what I didn't tell you, I have just concluding my PhD thesis in family medicine. And amidst all of that, we also have to do that.
Wow.
So you have to effectively manage time, and then you prioritize your activities as a way of managing burnout. You just don't do all your things without a plan.
One of the other things that you do is you've actually set up a primary care assessment tool. Can you tell us something about what that's used for?
The primary care assessment tool is actually my PhD work.
There you go.
Yes, and I know many people in the primary care, they know that the primary care assessment tool was developed by the late Barbara Starfield to try and develop a tool that would measure primary care performance in the different contexts. Her recommendation together with the team was that it should be adapted in the various contexts for use. And we have significantly done work on the primary care assessment tool in Africa. It was first piloted in South Africa, and then in Malawi, then in Kenya, and now I've done it in Uganda here. It is actually quite a good tool, but the challenge, of course, is that it needs adaptation, and we go through tedious process of adapting it in the various contexts, particularly in Africa. And we have found it to be a lengthy tool. And what we have done, we have tried to actually adapt it. What I've been mentioning are the works which have been done at country level.
You saying that leads us a bit to public health, which is also one of your special interests. And when I flew in this morning, the first thing that you realize when you step off the plane and you walk into Entebbe airport, it has massive posters on Mpox. And it looks like they're also taking temperatures again. And it reminded me a lot of COVID. Have you seen a lot of cases of Mpox as a primary care physician? Is that something that Ugandan primary care is concerned about?
I think to answer the first question, I actually haven't seen any patient with the Mpox. But it should be something that primary care should be concerned about, because you know that mpox has been declared as a public health emergency by WHO, and therefore we can't take that lightly. We know that mpox is an infectious disease, and of course, you know, this part of the world, we have really been ravaged by infectious diseases. And of course, you know, the mpox was first discovered in Democratic Republic of Congo,
which is not far away,
which is our neighbor, so which is not far away. So, and then we know that much as many people will recover, but if you can actually have severe disease, and there have been some reported deaths, and therefore that's why we don't take it lightly. But being a practitioner in the city, we don't commonly see those, because as you see, it is from monkeypox. Sometimes we think, though the reservoir is not well known, but we think that it actually comes from animals. So of course, wild animals are not in the city, so maybe that's why you haven't seen the cases. But also, whenever there are outbreaks in the Democratic Republic of Congo, we take serious public health measures to make sure that it doesn't spread. And that is why you saw in the airport many posters coming, because we know that yes, it may not be a terribly deadly disease, but some few people will actually suffer the severe disease and they may die. And you know, every life matters, and that is why we take extra precaution.
And I mean, you've probably got quite a lot of experience. I remember when I was in Uganda a couple of years ago and they had a hemorrhagic fever outbreak. Primary care was really concerned. I was in the northern part of Uganda and I think they handled it quite well. How come your primary care physicians are adapted so well to infectious diseases? Is that because they just don't have a choice, or?
I think you have answered the question. I think they don't have a choice. And you know very well that in medicine, we all become experts in the things we commonly do. And these viral hemorrhagic fevers, for example, Ebola, Marburg, and even others, we are always at risk. Everyone knows that any time an outbreak will come. And that is why Ugandans, and particularly Ugandan doctors, and including primary care doctors, we are actually experts. You know, if you actually find out more, even Ugandan doctors were key in the control of the devastating Ebola epidemic in West Africa. So we are really experts because we have been hit by these epidemics quite often, and I can confidently say that we have learned through experience. So we are quite experienced in epidemic control and epidemic management.
You must be quite experienced when it comes to infectious diseases and pandemics, and your entire country and your primary care system is. Do you have any recommendations for us Europeans who haven't had such big experiences when it comes to pandemics?
As people who have not suffered serious pandemics, you need to learn from us, and you know the world is now a global village. COVID is in China, in the next few days it is in Italy, and in the next few days it is everywhere else. So I think we need to learn from each other and learn together in the management of these pandemics. Of course, it is not always easy to learn pandemic management in real time.
No.
So, but you need to also learn the principles, epidemic control and management, and the public health principles and infection control. So I think there must also be some deliberate efforts for some people to come from Europe and maybe learn from us here in some kind of experiential learning, and you share with us who have struggled with these epidemics. People really have experience. We have a big number of, significant number of primary care doctors who have been involved in the design of surveillance systems, how to do case definition, principles of epidemic response, and all of that. So I think the expertise and the knowledge is there, and I think you can learn from us.
Oh, definitely.
And prepare for any worst situation, because the world is not going to be free of pandemics. Most likely we may even experience some which are worse than the COVID, and therefore I think from the Europeans need to also learn from us how we deal with these things. And I think even in the COVID, you know that we have, because of limited resources, people were worried about COVID. But I think we used what we had and we did what we can, and hopefully we actually emerged out of the epidemic with minimal damage.
You're quite right.
Yeah.
Thank you. I think these were quite wise words. Thank you, Innocent. We have a game in this podcast, which you might have heard in one of the previous episodes. It's called A or B game. It's been adapted from a German podcast. I'll give you word pairs, and the idea is to pick and choose as quickly as you can without thinking too much about them. If there's a pair where you really can't decide, or you think it's too political, or you want to put this down to discuss later, just say next or skip. And the idea is to really just try and say what comes to your mind. Are you ready?
Yes, I am.
Tea or coffee?
Tea.
Stethoscope or mask?
Stethoscope.
Ultrasound or stethoscope?
Stethoscope.
Communicable or non-communicable diseases?
Communicable diseases.
Entebbe or Kampala?
Entebbe.
Kampala or Tororo District?
Tororo.
Murchison Falls or Queen Elizabeth Park?
Murchison Falls.
Swahili or Luganda?
Luganda.
Luganda or English?
Luganda.
Luganda or Swahili?
Luganda.
Northern or Southern Hemisphere?
Southern.
Makarere University or Association of Family Physicians of Uganda?
Makarere University.
Southern Africa Fame Regional Institute or Makarere University?
Makarere University.
Teaching or clinical medicine?
Teaching.
Research or teaching?
Research.
Research or clinical practice?
Clinical practice.
Backpack or suitcase?
Backpack.
Plane or car?
Car.
Car or train?
Car.
Car or boda boda?
Boda boda.
Family medicine or primary care?
Family medicine.
Primary care or general practice?
Primary care.
Undergraduate or postgraduate?
Postgraduate.
5 years or 3 years?
5 years.
E-learning or traditional learning?
Traditional learning.
Hybrid or on-site?
On-site.
Work or holiday?
Work.
Morning or evening?
Morning.
Sun or moon?
Sun.
Rain or snow?
Rain.
Basic education or higher education?
Basic education.
Health systems or health professions education?
Health systems.
Research on non-communicable diseases or health systems research?
Health systems research.
Medical education research or health systems research?
Health systems research.
Hypertension screening or hypertension treatment?
Hypertension screening.
Making the diagnosis or recurring treatment appointments?
Making a diagnosis.
Primary care assessment tool or primary care healthcare teams?
Primary care assessment tool.
Of course. City or rural area?
Rural area.
Sweet or savory?
Sweet.
Sweet or salty?
Sweet.
Cocktails or mocktails?
Cocktails.
Focus or distracted?
Skip.
Email or call?
Email.
Public health or global health?
Public health.
Epidemiology or public health?
Public health.
National or international?
International.
Cook yourself or go out for food?
Cook yourself.
This is going to be difficult for me. Matoke or luwumbo? Typical Ugandan dishes.
Luwombo.
Maragi or bell beer?
Bell beer.
Program development or healthcare?
Healthcare.
Politics or healthcare?
Healthcare.
Research presentations or research paper?
Research presentation.
TV or music?
TV.
Pictures or videos?
Videos.
Working holiday or holiday work?
Holiday work.
Work-life balance or life-work balance?
Work-life balance.
Well-being or success?
Well-being.
Happiness or well-being?
Well-being.
Taking time or keeping busy?
Taking time.
That's it. Thank you very much. Were there any pairs that you wanted to talk about? Was there any pairs where you thought, oh, this is something I want to discuss?
I think where I did skip and not heard properly, which is focused or
distracted.
Yes, but I wanted to say focused, but
Focused.
I don't. Yes.
All right.
And I think the pairs I would love to discuss is basically global health and
Global health and public health.
public health. And I think I mentioned public health.
Yeah.
Yeah, because yes, global health is some phenomenon that you have not actually developed, particularly for us in this part of the world. And I think that is why our focus should actually still be public health.
All right.
When you look at all of the things, that's why I mentioned issues like communicable diseases, because that is our problem. And we are not about to get rid of them. Particularly, the effects of climate change is actually making our issues with infectious communicable diseases a bit more complex. And I think we shouldn't forget, because on the global scene, and when you look at most of the writings, people are saying, yes, communicable diseases are on the rise. But they never mention that they are on the rise, but the communicable diseases are not on the decrease. So it means that if we don't keep a close eye on the communicable diseases, we are going to put our focus on the non-communicable diseases, but the communicable diseases are still with us. They have not gone away. And I think that is why really public health and communicable disease diseases is really our way to go. And of course, you know that public health works together with primary care, because what we see in the consultation rooms should actually inform our public health approaches to health.
Innocent, thank you very much for all these insights. Thank you very much for telling us so much about Ugandan primary care. I still wonder how all this fits into one life. I'm very impressed. I was wondering, do you have any final comments or recommendations for our listeners? Most of our listeners are young trainees, a lot from Europe, but we have listeners from all over. Is there any recommendation that you can give them if they are currently in their training and they might find it hard and they hear from someone like you and they think, oh, how did he pull this off?
I think my first advice and recommendation is that you should always like what you do. And what I mean is that people should not come into primary care training or family medicine training maybe as a last resort, or that is what is available. So when you like what you do, it will give you the internal motivation to go through all of the difficulties that are there. I have mentioned all of these. We have gone through so many difficulties, but to keep the motivation going, because personally I love what I do. I would tell you that, particularly for our listeners who are not familiar with the African context, is that family medicine and primary care are not prestigious in this part of the world. When you go into family medicine, people used to think, what are you doing there? You know, if you say I am a surgeon and I'm an obstetrician, I am an eye doctor, everyone will stand up for you. When you say you are a family physician, someone say, what is that? Who are you? But we like what we do, and I think that as anyone who is young in family medicine, you have many more opportunities compared to the people in the other specialties, because primary care and family medicine offers diversity, which I think no other specialty does. If you're a cardiologist, your life is about the stethoscope, is about the chest and everything else. But in family medicine, you never get bored because you are doing so many things. And because of that, it actually even keeps you with wider knowledge, which I think is very important to us as individuals. The beginning of every journey is always not very enjoyable. You enjoy the journey along the way. So my other advice would be that don't get discouraged when you're just beginning. Start the journey, keep going, and you will see very many opportunities coming up, and you will enjoy the journey along the way. Of course, many people will not see many years from where they are, many years ahead. They tend to see what is happening now. But as you keep developing your career, gaining more knowledge in the primary care and the family medicine, things will be much more clearer. The third advice would be that whenever you are in any specialization, identify somebody who is quite senior in that profession, sort of a role model or mentor. But you know,
that's a very good.
Yes, so that you can act, even if you do not physically work with them or they do not physically interact with you. But you see, these days, they are all opportunities and platforms for what somebody is doing. And then you learn from their journey. So identifying a mentor or a role model is very important. It keeps you going. And where possible, if you can physically reach out to them, for example, you can meet them during conferences, you can meet them online in the webinars and all of that. And you learn from what they are doing and how they are doing what they are doing. It will make life easier, and you can figure out how to navigate the primary care specialty and space, first of all for your personal success and motivation, but also to where you can contribute to the world of primary care and family medicine. And I think if you really significantly contribute, you will be remembered for withstanding the difficulties, the people thinking that you went into family medicine and primary care because you couldn't afford to be a neurosurgeon, which incidentally is not the case. Because for me, I always say the most intelligent people should be in primary care, because that is where you need too much critical thinking. You really need a lot of knowledge and skill, as opposed to monospecialties, because you become perfect in one thing, which is much easier. And again, it is important as a younger person in families and primary care to join global associations and organizations and share with them, learn from them, because sometimes when you are in your own context, you may not know that the difficulties you are facing are also being faced elsewhere. But when you join the community of practice, the journey becomes easier. You learn how to deal with the challenges, because somebody somewhere has ever dealt with that challenge. You will not be reinventing the wheel. So I think that is, in a nutshell, the advice I can give.
Thank you, Innocent. That was very meaningful help. I think many people appreciate it. Thank you for having us here in your beautiful Uganda, and thank you for taking the time out of your busy day. Thank you so much.
You are welcome. And thank you also for coming to visit us, and we wish you a happy stay in Uganda.
Thank you very much.